And so, the antithesis of Dr. Safi's talk, we're going to have a final talk from Ong U on the frozen elephant trunk and the Liverpool experience.
Thank you. Thank you for asking me to talk about it. And when I was in Houston a few days ago, there was only 3 people that talk about open surgery in the whole meeting. Husband, Tony, and me, so I was a small dinosaur. So I'm talking about frozen elephant trunk, which is something different. Right. And all the approaches for the management of distal arch and proximal descending thoracic aorta has been quite difficult, no matter how clever we are. And then either from sternotomy cut across a kind of open book or through the left chest or 2 stages, it's not easy. And so all the conventional approaches are kind of not without any disadvantages and multiple comorbidities. And when the elephant trunk, conventional elephant trunk was first described in 1983, it is something new for sorting out this condition with a 2-stage procedure. That probably saved quite a few patients' life over the years. And then it's been very useful for extensive kind of pathology management of ascending arch and descending segments. And it's been simple. You just push the kind of invaginate the graft and then do the distal anastomosis, pull it out, and then you do the proximal anastomosis and different type of kind of arch and category reimplantation. Depends on your personal preferences. And then subsequent vascular intervention, the invention with these grafts, kind of sienna with a collar graft. And that's something that I was going to mention to John at the time. Having this collar is made a lot easier. We don't need to push all these branches into the descending graft to do the proximal, the distal anastomosis. So we just trim for 1 centimeter, kind of cuff, and then put it down and just stitch it around. So make life a lot easier. And with perfusion branch, as soon as you finish, you can start distal perfusion. And with the multiple sienna kind of branch graft, it's a lot easier for each vessel reperfusion. So that's been a kind of achievement in the kind of open surgery. And then, but still patients have to have a second stage, to have this completion second stage. And which is very often depends on the kind of pathology. It can be quite extensive thoracoabdominal aneurysm repair. And that the problem with 2-stage procedure is both stages carry quite kind of considerable mortality and morbidity, and that a lot of time for patient to recover first stage, and then the death during the interval. And some patients, they refuse to come back for second stage, understandably. If I'm in their shoe, after 6 to 8 weeks or 12 weeks to recover, would you come back for the second stage? Maybe even far more dangerous. So that's been a problem with these 2-stage procedures. That's why the frozen elephant trunk concept is introduced to kind of treat in the 1 stage, or at least make the second stage easier. And first described in 2003 by the same group, and then subsequently the Essence group has introduced that together with Yotek to have a surgical, the stent graft, endovascular stent graft attached home to the surgical graft, and then use as extension of elephant trunk to treat the proximal descending pathologies. And so we all know this first frozen elephant trunk was Evita. And Evita come with the kind of this straight direct connection of the surgical graft and stent graft, with a fairly simple delivery system, and they're designed to deploy over the guide wire. And you can either with a click release with there's kind of surgical graft is nitinol, kind of stent graft is nitinol stent, MR compatible, and then surgical kind of graft is the same as the braided polyesters. These kind of material tightly bound woven kind of material. However, first version came out, we found that the first the graft was very porous. There been quite a lot of problem with the porous graft, and then subsequently go to the second generation. And even though the fabric is still quite tightly bound, I still find it is still quite porous. And so, after giving protamine without giving all the product to clot it up, very often you still get quite oozy kind of surgical graft in the arch and ascending. And The stent graft is from 24 to 40 millimeter, at the length 130, 150, 160 available. And surgical cuff, there's no collar, but it is kind of, you can go up to the same diameter as kind of surgical and the stent graft. Delivery system is fairly simple, and you just have a kind of 3 button. It is park, neutral, and then drive. So you just put the position, put it to drive, and start, click, and release. It is easy. It sounds easy, it looks easy, but when you started deploying it, and you're trying to keep hold up in the position, you realize that you're holding the sheet and you're pushing the stent graft forwards. So you need to remember you're just holding in the right position, allow it to come up, because you're pushing the sheet so backwards. So that's an important thing. And then once you release, and next problem is sometimes the tip is, you can see on the lower kind of bottom, and it is a little bit quite rounded and over the guide wire. And then the stent graft is opened out, but you've got this surgical graft is sitting in there. Trying to pull that tip out sometimes can be a problem. The first case for us went well very easily. A second case, we were struggling to get it out. I remember that the clinical specialist from the company was having a kind of sweat from the top. But somehow I found a way of kind of manipulating with the kind of robots and trying to get it out. But that was the kind of, so one thing you need to do is push it forward first, and then get it released, and then gradually pull backwards, and that's how you get that introduced out. And then that's kind of the delivery system, and you can use a normal kind of 035 kind of stiff wire. Or U-type wire come with a device together. You can either put anti-grade or retrograde guide wire kind of introduction. For dissection, you need the kind of retrograde, and for the aneurysm, you can put the anti-grade guide wire. Usually it's fine. And then now as you have the positional 8, you can put it through the kind of over the warp, and you can then position it so you can at least see when you are releasing it, your sheet is coming backwards. And then configuration, if you look at the sizes of diameter of the stent graft and then the diameter of the stent, they're exactly the same, which is different from the new kind of the Vascutect Thoraflex. And the new device came out by Thoraflex Vascutect, and they work between the kind of the same kind of Hanover group with the Malex Retro and the Vascutect, and they brought out this Thoraflex hybrid. And this one has the advantages of Sienna collar graft with the 4 branch and attached to the Thoraflex and thoracic stent, with the collar about 1 centimeter kind of and the diameter all the way around. And then the good thing is all these branches there. And then the delivery system very short. And then there's a kind of small tip, the hole in the tip where you can pass the guide wire through. So you can use the guide wire, or you can deliver without the guide wire as well for the aneurysm. And that this guide, the delivery tip of the delivery kind of the shaft, you can bend it into malleable position to adjust the curvature of the proximal descending and distal arch, so you can introduce it into the proximal descending to mid descending without damaging too much. And then to have this sheet sitting on top of that, this is a cutter. That's to cut this the sheet which is holding the stent graft inside the sheet. And then this is the puller. And then as you pull it, it split the sheet against this cutter. And so then release a kind of stem from the distal to proximal. And one thing we need to make sure is when you're going to deliver, take out this wire once you're in position. If you keep the wire in the position when you're trying to deliver, it causes trouble. And then after that, there's a wire to hold the tip, to pull this one to release the wire which is holding onto the tip of the device. It is simple. It comes with the numerical numbers. So step 1, step 2, step 3. But unfortunate thing is that the color of the kind of the 1, 2, 3 is the same color as the plastic kind of sheet they're holding onto it. So sometimes difficult to find where number 1, where number 2, where number 3 is. And one difference between these two is the stent graft size is 28 to 40, but surgical graft is 26 from 32. And that's a major difference for me, really, because most of the aorta will honestly replace arch in the proximal ascending or mid ascending. you never get 40 millimeter ascending or the kind of distal and the distal ascending proximal arch or and then lower down. So very often we have to do the uncomfortable and tailoring of the anastomosis from the kind of this Yotech graft, big graft onto the aorta, which is not required for the Thoraflex. And indication at the moment, indication is for aneurysm and then acute and the chronic dissection. And I'll leave the indication for not until later on, then we can then discuss about it briefly. And look at the kind of some clinical result. We had this international registry for Avita Open Plus, started with Essen group, and then it shows from the 2005 to 2012, and 113 patients that register into that group, and there you see that the results. And the result in hospital mortality was 12%, and then in the 5-year follow-up was 78%. It is reasonably acceptable. And then I won't go to too much because the time is running out for us, so I'm just going to go to important ones. What we see is spinal cord injury, paraplegia in that group was 4%. And then this is 3 years survival. And the next important, I think, paper is from the Fred Moore group, where comparing conventional and the frozen elephant trunk. Then again, I'll just go on to the important bit of it. So when you compare the kind of conventional elephant trunk and frozen elephant trunk, main difference is you can see that more type A dissection is done in the conventional elephant trunk initially, but total percentage after frozen elephant trunk, percentage-wise is much higher. And then another thing is, and then procedure-wise, and the temperature is the difference between frozen elephant trunk and conventional elephant trunk. I think this is, I personally feel that it is maybe the progression in the era of the arch surgery. So frozen elephant trunk comes in and later, so probably that's the reason why more patients were done with the high and the warmer temperature than cooler temperature. And then when you look at one thing that my main concern would be that paraplegia incidence, and then there's 4% in the conventional elephant trunk, and 21.7% in the frozen elephant trunk. And I think most of us done the total arch replacement and the 2-stage operation for, if it's just a mainly proximal descending thoracic aorta, the risk of paraplegia is very, very low in amateurs' hands like somebody like me. So I think 21% is quite high to accept for this kind of treatment. And let's move on to the kind of survival. And if you have a type A, your survival is slightly lower because the early kind of mortality is higher and compared to aneurysm or disease. And then one thing that I find I can't understand that there still is 6-year survival in the frozen elephant trunk group is lower and compared to conventional elephant trunk. So we still need some more data to understand what's been happening with these. And so the way that they conclude it, they find it temperature warmer than 28 or circulars time more than 40 minutes are the kind of correlating to the kind of increased incidence of paraplegia. So as we started doing more and more arch procedure with cerebral protection with warmer temperature, when we then extend our procedure into the proximal descending with the frozen elephant trunk, we need to be cautious about whether we are actually protecting the spinal cord as well as we should be for these procedures. And then Thoraflex has started that post-market registry, and 67 patients entered so far, and even though they've done over 200 patients. And these are the kind of rough data. We still need to wait and see how much of the kind of, they're treating quite a lot acute dissection and the chronic dissection and with the Thoraflex. And then device usage is across the board is a kind of, but quite a lot of devices, around 28 is kind of commonly used. And these are kind of basic data on the I don't think at the moment it's too meaningful unless we get more data and that we can then compare together. And then these are some data on discharge and adverse events from the post kind of market. So next thing is NICE guidelines. Some of you who involved with this review for the NICE or is in this room already, so I'm sure you're involved with that. So NICE did a kind of review and then produced a guidance for using Avita Open Plus for treating complex aneurysm and dissection in thoracic aorta. And come up with this guidance there's enough evidence they felt that to use it for the kind of Avita Open Plus for treating complex aneurysm and the dissection of thoracic aorta in the selected patient group. And then the main reason to avoid second procedure and associated serious complication. And then that's the reason why. And if you require second procedure and then this complication rises, then we cannot be saving money, which is there's some assumption that if there's no second stage required in 10 years' time, this is amount of money likely to save with the kind of so that's a kind of recommendation based the information based on the NICE guidance. We done 19 patients and 3 Thoraflex and 16 Avita, and these are kind of the original kind of with the 2-stage elephant trunk procedures and for the chronic dissection. We still don't use frozen elephant trunk for chronic dissection because we feel that we feel more comfortable doing the kind of 2-stage procedure if patients fit. And we do occasional TIVA and extension to complete the second stage elephant trunk. And then so this is the type of patient that we will go ahead and do the kind of frozen elephant trunk proximal and descending thoracic aneurysm where you can, and rather than defringing and then this aorta, we just put the Thoraflex on through there. And this is the kind of post-op results. And then we do for ascending root and proximal descending aorta, we will kind of replace and put that in the Avita at the same time. And then some chronic dissection where the dissection stop in distal arch and proximal descending aorta. Sometimes we will then put the frozen elephant trunk to cover that, and like this. And then some patient with acute type A dissection with a limited DTA involvement, and some of these patients we will put the kind of Thoraflex or Avita to cover that, and then that seemed to help and then remodel the kind of thoracic aorta. And I'm not going to go too much about that because it's a very small number. Main comparison is Avita Open Plus and Thoraflex. One thing is that there's no perfusion graft on Avita, which is a major disadvantage. When around 2007, 2008, I suggested that we would like to have a kind of perfusion branch. I'm sure most of us were involved at the time, and that the company felt it was not feasible. And then a few years later, we now got 4 branches with a collar. And then not having collar, sometimes anastomosis can be difficult, especially with the kind of big aneurysm or aorta and the distal arch. And the graft material more porous, and the graft extent diameter the same, so it's difficult for proximal anastomosis. And then these are the kind of advantages. But one disadvantage with Thoraflex, I find it, is sometimes the collar and the branches are very close. One. And sometimes you don't need the branches for arch replacement. Some procedure, your branches are in the way. It's easy to tie on, cut it away, but still it can be in the way for sometimes. So that's something that we don't like. But the companies are planning to bring out a single branch version, hopefully in next year or so. So hopefully that will kind of be helpful for us. And another thing is even though delivery system is short, it's still to some extent a little bit cumbersome. But we can get around it, but I think newer delivery system and the newer kind of refinement will require to improve on the delivery system. And so conclusion is frozen elephant trunk techniques in the selected patient allows the kind of single stage procedure to treat the arch and proximal descending aorta and dissection. And both available devices are good, but require further refinement. And for the long-term data required for all these procedures to delineate their future roles in the kind of the surgery of the aortic arch and descending aorta. Thank you.
Oh, thank you very much indeed. Do you have any questions for Mr. Wu? I'd like to know more about the Thoraflex that's coming. I've seen it, but we've no experience of it. Do you think it's going head to head with Avita, or do you think that you need both on the shelf and you use one?
Both on the shelf. The reason is sometimes when I have a patient where I need to treat just proximal descending thoracic aorta, what we did in the past was we will just put and they'll do the distal anastomosis, and then we almost kind of cut it like a reverse elephant trunk. The reverse hemi-arch, and suture to the arch and close it up, and easy to do that. But if you have with a Thoraflex at the moment, all these branches are everything in the way. Another one potential problem with Thoraflex at the moment is you need to be careful with your branches. When the whole thing is wrapped up in the kind of delivery system, it can be very confused because you're on the circle rest and something new device in your hand, and then you're trying to assistant talking to somebody is talking to on top, and you're trying to look at it. You can easily deploy the Thoraflex with slightly twisted, maybe 15, 20 degree or 30 degree twisted in a position. Then you're stuffed with the kind of branches in the wrong direction. Then you probably ends up chopping it up. So at the moment for me, both of the devices are required. Their places in the kind of present practice.
Right.
But all these methods of putting graft, whether by surgeon or by stent, is still the rest of the aorta could get big. So, to me, I don't know why you complicate the matter. That's what I think. You don't have to, for acute dissection, especially in the ascending aorta, you want to get the hell out of Dodge City. You just get him alive and take care of the rest. And with the open technique, removing the lesser curvature of the transverse arch, somehow the transverse arch doesn't get dilated. So this is what my puzzle, because the rest of the descending and the abdominal is going to get big.
I'll give you the one example why I will use it every time. We had a patient, 88 years old, Welsh farmer lived halfway up in the Snowdonia. He had a rupture and contained leak of the distal arch proximal descending. And if I tried to fix it through the left chest, he would be in big trouble. So we went through the front and then deployed the Avita at the time, open plus. And then he was discharged 2 weeks later, and he went back onto the mountain, and then he's been happily enjoying his life. And if I did a Tuesday procedure or through the left chest with circus, I think that he would probably in a big trouble for at that age. And there's another patient that did recently with a Thoraflex, is 24 years old, I think, from Manchester Royal, and had the patient had the right-sided arch with the aberrant left subclavian artery coming distal. So it is in the lower proximal descending thoracic aorta in the right chest, and the transection was between the right and left, the left common carotid and the left subclavian artery, which is right transection part is right in the middle of the midline behind the trachea and esophagus. Couldn't reach it. We can't stent it from the kind of retrograde as usual. We couldn't reach from the left chest. We couldn't reach from the right chest. So I went through the front, and then deploy the Thoraflex, and then I just replaced, because of the, if I have a kind of collar without branches, one branch I would be delighted, but there was all the branches, so I replaced 2 branches because to make it safer. But that patient was treated very well with that. These are some application of these new devices to be able to treat probably kind of relatively simpler and safer way, I think. But one thing that I wouldn't agree or support at this point in time is doing this Thoraflex or Avita into all the acute type A dissection, replacing arch and put it down in the true lumen. I think it's a wrong thing to do, especially with a patient with connective tissue disorder as a Marfan. We are committing these patients, young patient, with a stent, and then second stage, either stent or the kind of hybrid type of operations. And then with lifelong and the imaging and the radiation kind of exposure. So I don't personally do it, and I wouldn't support it at this stage.
Oh, thank you very much indeed. Thank you for everyone for your patience. Just before you go, I would like to thank all the speakers. There's been an awful lot of input into so many presentations. There's been a lot of science, a lot of entertainment, and I'd like to thank everyone and you for your attendance. Thank you.